The topic of the heart, heart is a very important viscera, and heart is a very important viscera, and this viscera having a arterial circulation. Most of the death in the worldwide is due to this organ. Okay, the leading cause of the death is lack of blood supply or oxygenation to the heart. Okay, or due any other factor or heart blockage, etc. Okay, this is the leading cause of death. So I am reading the anatomy of the heart. An anatomy of the heart is incompleted without the vascularization of the heart and the nerve supply of the heart. Because vascularization is the reason why there is a pain. If there is a lack of blood supply, so on. I want to clarify two important words. Number one is myocardial ischemia. Myocardial ischemia. And that means myocardial ischemia means lacking of blood supply and damage to the myocardium. Actually, it's not true damage. Damage to the myocardium is reversible. Okay, यहाँ से आप revert कर सकते हैं. The reversible. But if it is irreversible, there is a loss of the myocardium due to the time which is taken by the lacking of the oxygen supply, that is known as myocardial infarction. The two things, myocardial ischemia and the myocardial infarction, is two different terminology. Okay, and these are due to lack of the blood supply or lack of the oxygenation. But important thing, the beauty of the medical science is pain. You can feel the pain of that thing, ischemia, or if it is persisting more than half an hour, they say that is almost, suppose this is an infarction. If you are working on the ischemia, if the proper care is given to the patient, probably patient can be saved. 1 hour for this thing is very crucial. 1 hour is crucial. So you have to identify what is the pain of the pattern. I want to show you some pattern by role play. Okay, one patient is obese, smoker, diabetic, comes here and with a lot of pain is here, and this is radiating toward the medial aspect of the arm, not the lateral aspect, medial aspect of the arm. Probably that person is suffering from the same ischemic pain of the heart, and this pain which is behind the sternum and radiating toward the medial aspect of the left arm. In most of the cases, I am not saying the right arm, this most of the time medial aspect of the arm, that is known as angina pectoris. Angina pectoris. Okay, angina pectoris is this one. Okay, three terms: myocardial ischemia, lack of the blood supply, lack of the oxygenation, reversible loss or reversible impact. Irreversible loss to the myocardium, that is known as myocardial infarct. Myocardial infarct, and that in fact may lead to the cardiac block also. And many a death occurs due to the infarction, this one. Okay, that all kind of the loss occurs. इसे दोबारा start करना पड़ेगा ये कुछ होता ही है. Infarction and this one. Okay, on right.
कोई नहीं edit हो जाएगी.
Okay, so these all are the features we discussed. What are the features? How this is working? Now two concepts are clear: lacking of the blood supply and senses which is carried by the pain. Both should be read. Because this pain having an anatomical basis, we will read now the nerve supply of the heart. Nerve supply of the heart. Okay, and the nerve supply of a viscera is carried by the autonomic nervous system. Viscera is not served by the somatic nervous system. This is served by the autonomic nervous system. Autonomic nervous system. We will discuss in this lecture how this autonomic nervous system is serving, how the pain sensations are working. Okay, in this one. Diagrams regarding this. Okay, this is served by autonomic nervous system. Okay, and for this is supplied by a superficial cardiac plexus. For this, a superficial cardiac plexus is there, and two deep cardiac plexus is there. You know the plexus? Plexus is intermingling of the nerve fibers. And why we are saying that is a deeper one and superficial one, I will discuss here. Okay? Let's start to draw a diagram in which I am forming trachea, which is supposed to be formed by the hyaline cartilage. Right bronchus, more vertical, more broad. Trachea, less broader and more angulated. This is the bifurcation of the trachea, and you can see the carina. Okay? This one. The deep cardiac plexus is situated on both sides. This is the right cardiac plexus, right deep cardiac plexus. This is the left deep cardiac plexus. This is the right deep cardiac plexus. This is the left deep cardiac plexus in front of the bifurcation of the trachea. One thing is very clear, the deep cardiac plexus are two in number and these are situated in front of the bifurcation of the trachea. Two deep cardiac plexus. Okay. Below this, I am drawing the musculature of the heart. I'll show the musculature of the heart. This is supposed to be the right atrium. Right atrium. Atrioventricular groove. Atrioventricular groove, especially the right side. So this is the right atrioventricular groove. And you know the importance of right atrioventricular groove. I think you know the importance of right atrioventricular groove. Right atrioventricular groove having a right coronary artery. Right coronary artery. Okay. Then there is the right ventricle. Then there is right ventricle and anterior interventricular groove. And I think now you also know the importance of this anterior interventricular groove. This is the left anterior descending artery. Left anterior descending artery. One more. Here it is. Partially this one that is indicating the left ventricle. The left ventricle. Both sides of the heart there is the root and hilum of the lung. This side, right root of the lung or hilum of the lung. Hilum is opening, gateway, and root are the structures. So I am just drawing the hilum. This is the left hilum of the lung, indicating the pulmonary musculature and the trachea. Okay? Now, at the junction, a valvular presentation, the valve is there, cusp is there. An emerging aorta. I'm not going in the detail of the branching of the aorta. Okay, and just below this we can see here is the pulmonary trunk. You better know the pulmonary trunk going below the arch of aorta and reaching posterior to the arch of aorta and dividing into the pulmonary arteries of the right and left side. Okay, this is the pulmonary trunk and this is the right branch. Now, in between the arch of aorta, just below the arch of aorta and near to the right pulmonary artery, there is another plexus, and this plexus is known as superficial cardiac plexus. I think now it's very clear the bifurcation of trachea lies in the posterior mediastinum. Anterior the heart is there. Okay, if you are not removing the heart, probably you are unable to see the bifurcation of trachea. So it is situated deeper in comparison, and this is on the superficial side. It is between the right pulmonary artery and this one. That is aortic window. Okay, and is just right to the ligamentum arteriosum. Ligamentum arteriosum. This is the superficial cardiac plexus. So two deep cardiac plexus, one superficial cardiac plexus is lying here, these are serving the heart. How they are serving? That is important. First of all, we have to discuss how the superficial cardiac plexus is formed. If I want to draw this one again, first of all, the aorta, and on a right side of aorta, there is a branch that is known as first branch is known as brachiocephalic trunk. Next is this one is left common carotid, and third one there is left subclavian. These are the branches of the arch of aorta, and so I am drawing this arch of aorta here. This is arch of aorta, and below the arch of aorta, same, the pulmonary trunk. The pulmonary trunk. Right pulmonary artery, left pulmonary artery. In between them, somewhere here is the superficial cardiac plexus. First and notable thing is that how it is formed. It is formed by the sympathetic cervical ganglion. Superior sympathetic cervical ganglion is sending direct branch to this one. And two vagal branches, two cardiac vagal branches is contributing. Two cardiac vagal branches is contributing to this one, that is known as superficial cardiac plexus. I want to tell you here, the vagus is indicating the parasympathetic contribution to this superficial cardiac plexus, and the other sympathetic ganglion is indicating the sympathetic contribution. How it is formed? Sympathetic contribution is carried by the sympathetic ganglion of the neck, okay, and the parasympathetic contribution is done by the vagus, okay. What is the important? I will tell you what is the difference between the sympathetic and parasympathetic. Vagus again. So vagus is contributing whether in a deep cardiac plexus or a superficial cardiac plexus. Vagus is indicating the parasympathetic contribution. No other contribution of the parasympathetic coming from anywhere. Okay. Dorsal nucleus vagus, a nucleus ambiguous of the vagus nerve contributing to the parasympathetic. There is a great importance because parasympathetic reduces, basically parasympathetic work on the SA node and AV node, and it decreased the rate of the heart. It decreased the rate of the heart. Simultaneously, because heart is slowed, heart is sluggish, less coronary circulation is needed. It's also diminishing the less coronary circulation. So, whether heart is slow, but chances is more for the attack. So, God provides us a difference. Large coronary artery is not supplied by the vagus nerve. Smaller coronary artery are supplied by the vagus nerve. Okay. So, these are two, and this is the formation of the formation. It is a formation of superficial cardiac plexus. Now coming to very important contribution. The first and foremost is the deep cardiac plexus, and for formation of the deep cardiac plexus we have to draw the trachea, the bifurcation of the trachea, and right side broader, less angulated, left side more angulated and narrower trachea. This, and I told you the trachea having a bifurcation, and in front of the bifurcation there is deep cardiac plexus. These are two in number, but in this diagram I am showing just one. Okay, to avoid the messy diagram, I am just showing the one. Here it is. First and foremost, I want to describe the parasympathetic contribution. And you know, parasympathetic contribution comes through the vagus nerve, heart. Okay? So there is a ganglion of the vagus nerve traversing like this one, and it give a recurrent branch here, recurrent laryngeal nerve contributing to this one. By the inferior cervical ganglion, it is contributed of the right side, just talking about. And other cardiac branches of the vagus nerve also contributing this. One inferior cervical ganglion branch, this one. Now, on the left side, vagus nerve, the ganglion of vagus nerve contributing to this. The inferior cervical ganglion is not contributing on the left side. That's the difference. Cardiac branches of vagus of both sides, simply the ganglionic branch contributing to this parasympathetic of deep cardiac plexus, but not this one, the inferior ganglionic. One more, the superior, okay, this one, and rest, the recurrent laryngeal nerve of left side is more at the lower side. It is also contributing to this. Both side recurrent laryngeal, both side cardiac branch, except the left side inferior cervical ganglion branch of the vagus nerve is contributing to the parasympathetic nervous system of the deep cardiac plexus. We form the deep cardiac plexus is here. And lastly, last cervical branch is there, vagus is going downward. This is parasympathetic कंट्रीब्यूशन. ये वेगस है, और जब आप वेगस नर्व के बारे में पढ़ेंगे, इसीलिए if a person is not good athlete, a person is lazy, vagal tone is low. If the vagal tone is low, the heart rate is high, parasympathetic is not working. The person or the people who usually didn't do work in their home, the pulse rate is high, 90 plus, so on. And as soon as they start to exercise, pulse rate shooted more, and there is a palpitation, घबराहट होने लगती है थोड़ा काम करते हुए. Okay, and those who are athlete having good vagal tone, their heart rate may be 60, 50, 40. That is known as vagal bradycardia. Vagal tone, high vagal tone bradycardia, athletic bradycardia. This is known as athletic bradycardia. Okay, one thing is clear. If you want to reduce the heart rate, you have to give the parasympathetic mimetic drugs. If you want to raise the heart rate, you have to give the sympathomimetic drug. Okay, that is also a very important component of the heart. Now coming towards the again sympathetic contribution. Again the trachea, less angulated right side, broader right side, more angulated left side, tracheal bifurcation, bronchus, and here it is the deep cardiac plexus. Now sympathetic innervation, that is very important. 3 sympathetic ganglion in the cervical region, the superior one, the middle and inferior is known as satellite ganglion with the T1, and then sympathetic chain having a T1, T2, T3, T4, all the branches from the right side, superior sympathetic ganglion, intermediate sympathetic ganglion, the satellite ganglion, T1, T2, T3, T4 and T5 on the right side. On the left side, the superior cervical ganglion, satellite ganglion is not contributing. Then intermediate, then satellite, T1, T2, T3, T4, T5. Okay, this is not contributing. That's it. This T1, T2, T3, T4, T5, all contributing to this one. There is a difference, a little difference in the parasympathetic of deep cardiac plexus on the left side. That inferior cervical ganglion of the vagus is not contributing. In the sympathetic one, which is contributed by all three sympathetic ganglion of cervical region, and the T1 to T5, the which is not contributing on left side is superior sympathetic ganglion, is not contributing on the left side. So discrepancy occurs on the both side, both sympathetic and parasympathetic. Are you aware? Parasympathetic is reducing the heart rate. As soon as you are doing the sympathetic one, heart rate is increasing. You know, any harsh sound of a flashlight on your face, any such kind of condition which is secreting adrenaline, fast rush, heart rate is increased. Heart rate is increased. Okay, and when heart rate is increased, you need to vasodilate the coronary artery. Otherwise, there is a protective mechanism. Especially the coronary artery dilates, but the epicardial vessels constricts. Notable thing is here, the sympathetic is not only increasing the heart rate, it also carrying the pain fibers everywhere in the body. The sympathetic nervous system carries the pain fiber from the viscera. You know, viscera having no somatic fibers. The sympathetic. So sympathetic nervous system is contributed by T1 to T5. And you know, remember the dermatome. See at T1. यहाँ chest में T2 से start करते हैं. T2, T3, T4, T5, T5. So pain will be like here. Retrosternal pain that will be radiate to the medial aspect of the arm. Clear? Due to the dermatome T1. T2, T3, T4 from the sternum or first area below this one. Because hand having C4 to C8, T1 goes in the arm, then T2, T3, T4, T5. So if there is a ischemic pain and hearting feeling a pain, definitely ischemic pain is one of the severest pain. Okay? If you are feeling the chest pain is retrosternal, mostly on the left side. It's a heaviness in the chest which is radiating toward the medial aspect of left arm. Medial aspect of the left arm. This is the typical presentation of the angina pectoris. Or why it is happening? Due to this. You know, the T area or T spinal segment are not working for the superficial cardiac plexus. Now coming to various contributions. This is formation. Formation is simple. From the sympathetic ganglion, one branch, two branch from the vagus, superficial cardiac plexus. On this side, parasympathetic is contributed by the vagus, different cardiac branch of vagus. Here, except the inferior cervical branch of the vagus, all the branches of the vagus. Here, so all three sympathetic ganglion both side, except the superior one on the left side, and T1 to T5. This is the contribution. Now, important thing is how they are correlating. This superficial, I am drawing the coronary artery. This is representing the right coronary artery, and this is representing the left anterior descending or left coronary artery. It is representing the circumflex branch. Just a representation. Okay. Now, the superficial cardiac plexus give three branches. One branch is going to the coronary artery, right coronary artery. Okay, it is situated in this one, and this is known as carotid plexus. Right carotid plexus. One branch. Right carotid plexus. Contributing to right carotid plexus. Another branch is giving to the pulmonary plexus. Contributing to the pulmonary plexus. And third branch to the communication branch to the deep cardiac plexus. The communication branch to the deep cardiac plexus. Three branches. One branch communicating to deep cardiac plexus. Second branch, it is situated to a little bit toward the left side, but it is contributing to the coronary plexus and left pulmonary plexus. Left pulmonary plexus, right coronary plexus, and communication branch, three branch. Formation ye hai, and this one is the contribution, three branches. Now coming to the deep cardiac plexus, and we are separately talking about them. When we are talking about this one, that is right side, I'm just forming a one pulmonary artery. that is right pulmonary artery. It giving a branch which is going anterior to the pulmonary artery, and this branch is divided into two. One is going to the right pulmonary plexus, another branch is again contributing to the right coronary plexus. The branch which is going behind this one, okay, this is behind, is contributing to the right atrium. It's also going here, giving a branch to the left coronary plexus, right atrium and left coronary plexus. This plexus or deep cardiac plexus, this is giving two branches. One is going to the left pulmonary plexus and another is contributing to the left coronary plexus. This is the distribution. Okay, फिर से शुरू करें. थोड़ा सा confusing हो गया? Okay, nothing to worry. The superficial plexus giving three branch. It is toward the left side, left pulmonary plexus, but right coronary plexus, and one communicating. That's it. The right side deep cardiac plexus giving two branches. One is anterior to the pulmonary artery, the right pulmonary artery. One is posterior to this. Anterior branch is contributing to the right pulmonary plexus as well as the right coronary plexus. Coronary plexus toward the coronary artery. Simple, very simple. The posterior branch is special, which is going toward the right atrium. It is also supplying the right atrium. Why right atrium? Why not the ventricles? Because there is parasympathetic is needed. SA node, AV node is needed there. Okay. This is the branch posteriorly going right atrium as well as the left coronary plexus. There is a vice versa relation between the superficial and deep cardiac plexus. Okay. Now the left side deep cardiac plexus giving a left pulmonary plexus as well as a left coronary artery. Both the coronary plexus is supplied by twice branches. Okay, clear? That's clear. Okay. This is the distribution of the branching pattern of the deep cardiac plexus and the superficial cardiac plexus. Overall, the vagal nerve is contributing to the superficial one and cardiac as well. So, is this the parasympathetic or myomatic? What's mean parasympathetic? Anyway, whenever the vagal tone is high, the acetylcholine will be released and basically vagus or parasympathetic work on the SA node and AV node. You better know conductive system, AV node, SA node. Its own conductive system of the heart is there. Rhythmicity is there. So, what is the job of the sympathetic and parasympathetic? Just regulate them, not to work with them. They are not improving the rate. They are not generating the heart rate. Actually, they are regulating. And when the parasympathetic work on SA node and AV node, that's it. For two places. That is reducing the heart rate. With the reduction of the heart rate, there is a reduction of the vasoconstriction of the coronary artery. That means that may lead to the death of a patient. But protectively, the large vessels are not supplied by the parasympathetic one. So, heart rate can be reduced up to a mark with a safe results. Okay? Sympathetic, increase the heart rate because body demands the blood. Now you are in a position, in an unsafe position, large sound, a fear, flight reaction, heart rate is increased. If you are running, heart rate is increasing. Sympathetomyomatic is working. And if heart rate is increasing, there is a need of the vasodilation of the coronary artery, especially the small vessels. Okay? So again a protective mechanism. When heart rate is high, you need a vasodilation of the pulmonary artery. Okay? T1 to T5 are the contributing spinous segment. Not only that, I told you, there is a typical presentation of the coronary artery. Angina Pectoris is there. Then, okay? This and vein is radiating toward the middle. That typical patient, you will get this typical patient. But some atypical presentation is also there. Heart is formed in the cervical region. And the many nerves are serving in the cervical region. Pain may be radiated to the neck. Pain may be radiated to the neck sometime. A very typical history that tooth was extracted due to this pain. And this pain doesn't belong with the tooth. That was the angina. Angina. Those angina which appear in the pectoral region is known as angina pectoris. But this angina may radiate to other teeth. This angina may go in the epigastrium because the fibrous pericardium as well as the lesser omentum is developed from the septum transversum. So this may appear into the epigastric region. May. Okay, and that may radiate to the right side also. If a boring, heavy pain is there, that may radiate to the right side. May. Okay, lesser chances radiate to the neck, lesser chances to the epigastrium, lesser chances to this one, and more chances of typical presentation of left pericardial pain, which should be identified with you. A surprising fact regarding this one. Surprising fact is the autonomic nervous system is dumped or damaged by the high sugar level up to the few years. So up to 20 to 30% diabetic patient who are more prone for the myocardial infarction doesn't feel any pain. They feel some kind of palpitation, some kind of perspiration, some kind of uneasy feeling, and immediate after 1 hour so on, there is a casualty of such kind of patient. Beware of that. What is angina pectoris? What is the anatomical basis? What is the anatomical basis of angina?